So we're going to be off the starting blocks again in just a moment with Professor David Wood, who many of you will know is Professor of Cardiovascular Medicine at the International Centre for Circulatory Health at the National Heart and Lung Institute, Imperial College. Ladies and gentlemen, Professor David Wood is going to be talking to you at a rate of knots about a third way of achieving cardiovascular health. Over to you.
Thank you. Scientific evidence for prevention of cardiovascular disease is compelling. Both secondary prevention for those who've survived the initial ischemic insult to the heart or brain, and primary prevention in asymptomatic high-risk individuals identified through health checks, all needing cardiovascular risk reduction. The underlying arterial pathology for heart attacks and strokes is atheroma, which progressively obstructs the lumen of the artery. Rupture of the atheroma, releasing cholesterol into the lumen, results in instantaneous thrombosis and a blocked artery, the immediate cause of a heart attack or stroke. For the patient, the first manifestation is chest pain or weakness in the case of stroke, leading to early admission to a heart attack or stroke center, followed by angioplasty, stenting, or thrombolysis, and a prescription for a battery of 5 or more life-saving drugs. This is the challenge we face. This patient had a blocked right coronary artery, seen on the left, opened by angioplasty and subsequently stented, restoring life-saving blood supply to the heart muscle. On her feet on day 2, discharged home day 3, job done? Absolutely not. The atheroma is, of course, still there. The major cause of atheroma is our lifestyle: smoking tobacco, eating unhealthy foods, and sedentary behavior. Our unhealthy lifestyle progressively increases our cardiovascular risk until it is sufficiently high, as identified through health checks, to require a professional lifestyle intervention. And this is the biggest challenge we face in the delivery of preventive care for high-risk patients, because it requires specially trained healthcare professionals, nurses, dietitians, physiotherapists, physical activity specialists, and others to deliver a behaviorally based lifestyle program. And our unhealthy lifestyle also results in elevated blood pressure, raised cholesterol, growing obesity, and central obesity, leading to diabetes. And these risk factors also need to be measured, monitored, and managed effectively. Is there any difference between secondary and primary prevention? Dick Cheney on the left demonstrating his heartmate, and Sadiq Khan on the right, who might be at high risk. What is the difference? Simply this: plaque rupture and an asymptomatic high-risk individual becomes a patient with a heart attack or stroke. So actually both asymptomatic high-risk individuals and patients with vascular disease all require a professional lifestyle intervention using a behavioral approach, addressing smoking cessation, diet, physical activity, and weight management, and taking account of psychosocial factors. And beyond lifestyle management, the other major risk factors, blood pressure, lipids, and glucose, need to be systematically measured, monitored, and managed to targets. And finally, understanding the importance of adherence to life-saving medications. Where should this care be given? In hospital or in general practice? Are cardiologists and general practitioners trained to assess the complexities of diet, physical activity, and exercise? Are they trained to give a professional, comprehensive lifestyle intervention? And do they really have the time to do so at scale? We need a third way: neither hospital nor general practice, but rather community facilities, public leisure spaces, sports halls, community centres, village halls, and so on, close to where patients and families live. And who delivers this care? A nurse, prescriber-led, interdisciplinary team involving dietitians, physiotherapists, and other healthcare professionals, providing a rolling, comprehensive program integrating secondary and primary prevention for both patients and families. We were commissioned to deliver this nurse prescriber-led integrated prevention program, combining secondary and primary prevention for a population in northwest London, through community centres serving more deprived and ethnically diverse populations. Dr. Connolly led this service. Teams were trained through our master's degree program in preventive cardiology at Imperial College. They followed an evidence-based health professional manual, now published by Oxford University Press, and service delivery was quality assured and audited. A behavioural lifestyle intervention was delivered by the nurses, dietitians and physiotherapists to patients and their partners. Blood pressure, lipids and glucose were monitored and managed by the nurse prescribers, and adherence to cardioprotective medications was supported. Lifestyle, risk factor levels and drugs were all recorded at baseline, at 16 weeks and again at 1 year, and showed significant improvements in smoking cessation, in diet, in physical activity, and better control of blood pressure and lipids, all peer-reviewed and published in Heart. But most importantly, a cost-effective analysis of this program revealed that for every £1 invested, there will be £6 in savings over the lifetime of the patient. So not just a cost-effective service, but a cost-saving one for the NHS. So it is possible to deliver a third way of preventive care. Not hospitals, not general practice, not doctors, but through nurse prescriber-led interdisciplinary teams working with patients and families in local community facilities. And in Galway, on the wild Atlantic coast of Ireland, is Cree, which is Irish for heart. And this is a purpose-built community heart and stroke centre, delivering preventive care to vascular and high-risk patients in Galway, with multidisciplinary teams reaching out to surrounding rural communities. A third way is already here. Thank you.